This is me, Dr. Ghada, your instructor today. I hope you're all having a great day. Hello, Dr. Koshik, how are you?
Hi, madam. Good day. I'm doing good, ma'am. How are you, ma'am?
Yeah, I'm fine too. Thank you. I hope you reviewed the previous 3 classes, class 15, 16, and 17, because they are all connected. And our core principle is interactivity. To get the best out of this class is to interact. This is a good chance to practice and to test your understanding and your knowledge. All right? This is the fourth and the last class on confrontation visual field tests, and it's all about questions, quizzes. And also, if we have a good number of participants, we may play this game, Kahoot game, towards the end of the session. So in order to join the Kahoot game, you will need another device to be connected with the internet, most probably a phone. I will talk about the instructions later on, and we will see who will be the top 3 winners. And mistakes are welcome today. Yeah, miss it today, master it tomorrow. So we all make mistakes countless time, and this is part of our learning process. So don't be shy. So I have some warm-up activity before the questions themselves. It's fill in the blanks, and we covered this before in the previous classes. The first one, the right optic tract carries information from the blank hemifield of blank eye. So you can write in the chat the missing words. And when it comes to some topics like neuro or strabismus, it's very easy to get confused. So try to participate and try to answer this question. The right optic tract carries information from, because this is very fundamental, and actually this is like a graduate level, not a postgraduate level at all. Yeah, exactly. Thank you. So the left hemifield of each eye. So better to say each eye instead of both eye, each eye. Because if we say both, the eye should be plural here, eyes, both eyes. So the left hemifield of each eye. Left hemifield of each eye. And that's why whenever we have a right optic tract lesion, we have a left homonymous heminopia. Just a quick revision on some of the diagrams that we shared before. As you can see here, this is the optic tract, the right optic tract. So as if you are looking at the screen. So this is the right eye and this is the left eye. And this is the right visual field and this is the left visual field. Okay, so left optic tract, we have the fibers, the temporal fibers of the right eye, which serve as the nasal field. And we have in the right optic tract, the crossed nasal fibers of the left eye, which serve as the temporal field. Back again. So the nasal field of the right eye is considered the left side of this field, and the temporal field of the left eye is considered the left side of this field. And that's why we say the left hemifield of each eye. Under binocular conditions, there is an overlap. So the end result that we have the left side of the binocular vision is lost. And we talked about this before. So the second line here, the optic nerve is formed of blank neurons. You can write in the chat. Again, this is a warm-up activity, and we haven't started the class yet. The optic nerve, which is cranial nerve number what? Yeah, it's cranial nerve number 2. Excellent. So the optic nerve, which is the cranial nerve number 2, okay, is formed of blank neurons. What is the missing word here? Okay, so this is a number of axons, but I'm not talking about the number. But actually, I'm not asking about the number of fibers. Okay. Yeah, it's a good answer, but this is not my model answer. Yeah, exactly. This is a second order neuron. So interestingly, the optic nerve is cranial nerve number 2, and also it's formed by the axons of ganglion cells, which is considered as the second order neurons. Excellent. So this is very basic. Yeah. So when it comes to visual pathway, we have photoreceptors, rods and cones. All right. The first order neurons are the bipolar cells. Okay. Second order neurons, ganglion cells. So the optic nerve is formed by the axons of ganglion cells, which is considered the second order neurons. This is really important, and it has some clinical significance that we'll talk about it in this class. Okay. And finally, we have a third order neurons in LGN, lateral geniculate nucleus. So the visual pathway is a 3-order neuron. Nice, nice, nice. So now it's time to start the meeting. We have 10 sets of questions. The last one is Kahoot game itself. All right. The first question is under this heading, catch me if you can. All right. So what do I mean by this? Catch me if you can. So me here is the blind spot, okay? And you is you, the candidate. Here I'm not talking about finding the blind spot in confrontation visual field because we covered this before and how we map the blind spot. But we are talking about catch me if you can, the blind spot in visual field printout, okay? So be ready to the first question here. It's a couple of questions under this heading, catch me if you can. So I need someone to unmute and answer this question. Now you see the question, comment on this picture and try to mention in your answer the type of perimetry and the program used and which visual field, is it right or left? Take a moment and think about this question, and if you are good to go, yeah, or confident to answer it, yeah, just unmute because I want to listen to your answers.
Right eye.
Dr. Kashik said it is the right eye. Do you agree or disagree? Okay, let's make it different. Dr. Kashik, for a certain reason, mentioned or said this is the right eye. Can anyone explain why he said this is the right eye?
This is left eye actually,
Okay,
because the
so
temporal field is more.
we should say right visual field, not right eye. So Dr. Kashik said right visual field, and now another participant said it's the left visual field. So I need a decisive answer here and why. So who said the left? Please unmute and tell me why you said the left.
Temporal field looks extended more.
Yes,
The temporal
exactly.
field.
Yeah, so you probably didn't watch my previous videos. The temporal field is more extensive, as you said, if we are mapping the full visual field. But here in automated perimetry, we don't map the visual field, the whole visual field. We are mapping just a certain degrees. Okay, so we have here 30 degrees in this side and 24 degrees on this side. So we are not mapping the full field. In order to map the full field, we need the kinetic or the confrontation test. So your assumptions isn't actually valid. So can you think about it again?
Sorry.
Okay, no, it's fine. We said before, make a mistake. I want you to make a mistake because we learn from mistakes. We try to dramatize our mistakes in order to remember them and learn from them. Okay, but yeah, good try. So, Dr. Kaushik, can you tell us why you said this is the right visual field?
Though the though we tell that the visual field is 24-2, but to pick up nasal field defect, which is the earliest field defect in glaucoma or one of the earliest changes in glaucoma, the 24-2 field, visual field in JAIS, Humphrey visual field, they have 24 degrees on the temporal side, but on the nasal side, it is 30 degrees.
Yeah.
So it is giving a PR-shaped shape of the visual field printout. So that makes a 24-2 field PR-shaped, and the PR, the sharp, the notch type thing is towards the nasal side, because that is there to detect the nasal step in glaucoma.
Yes.
So that is why I told that this is the right eye, right visual field.
Yes. Yeah.
And ma'am, another thing is this is difficult in this eye because we are not seeing the blind spot. If we are able to see the blind spot, then it would have been easier to say whether this eye was which field it was. But because of the constricted kind of visual field defect here, we are not able to see the blind spot. That's why the pattern of the field points becomes important in this kind of field.
Yeah.
And also another thing is I like to add that if there is a 10-2 visual field, because that is very smaller visual field, so you will not be able to know the eye because blind spot will not come there.
Yes. Yes.
Yes, ma'am.
Exactly.
Please continue.
Yeah, thank you. So this is a great tone printout, and the easiest way to know which field, right or left, is from the blind spot. But here, this is a constricted visual field, or like it's total, almost black, as Dr. Koshik said. So what is the blind spot? So indirectly, we can know the position of blind spot from the program. So this program is 30 degrees and 24 here. And this is called actually 24-2 program. So 24 on the temporal side and the 30 degrees on the nasal field to pick the nasal step in glaucoma, in early glaucomatous field defects. Okay, so the side with the 30 degrees is the nasal. Okay, and the side with the 24 degrees is the temporal field. And we all know that the blind spot lies in the temporal field because the blind spot represents the optic disc, which is located nasally. So since the blind spot in this side, in the right side of the screen, so this is the right visual field. And we talked about before, whenever we have a blind spot on the right side of the field, this is the right visual field, okay? As if you are mapping your eyes right now. You are looking at the screen. Just imagine you are looking at the screen and you are covering your left eye, okay? And you are mapping the right visual field. The blind spot should be temporally to the right side, okay? Excellent. So this is like a description. Now, do you have any comment on this picture? So what do you think this visual field represents? The appearance here is pathognomonic of a specific term, actually. Do you have any idea? So you see here a kind of a shape. Okay, some right in the chat. Yeah, exactly. Clover leaf. Okay. And what does it signify? So we have a leaf, and this is you know, a certain shape here. What does it signify, clover leaf? Yeah, increase false negative. So what does it mean to have a high false negative? Keep going. High false negative. So you have to be familiar with the terms. So this is the right visual field. Inattentive patient, out of fatigue or very tired. Yeah, exactly. So this is the answer. And this is the shape of a true leaf called clover leaf. And it's somehow related to how the visual field was mapped. Usually they map these areas, the whitish areas here, and the patient is still attentive, but after some time he gets or she gets tired and start to give false negative, and that's why there is blackish areas here. It gives a clover leaf appearance. And this affects the reliability of the test, okay? Definitely. Before we move on, the opposite of high false negative is high false positive. And the visual field appears whitish, super white, okay? So this is actually a field represents a high false positive results, which is called, what is the other term? There is a fun term, happy trigger. So you will see some supernormal sensitivities. So what we call these white areas. Does anyone know here what we call these white areas in the gray tone printout? There's white areas here. It's called white scotoma. Yeah, interestingly, white scotoma. And here there is in Humphrey a message under the glaucoma hemifield test shows abnormally high sensitivity. And actually, this is unreliable test because we have two X marks here, fixation losses high, and also false positive results or errors. All right. So this is called white scotoma. It means high false positive errors. Again, we're still in the first question, catch me if you can. We are talking about catching or finding the blind spot in the visual field printout. Okay, which visual field? Right or left? Now the program here is 30-2. We have 30 degrees here and 30 degrees here. It is impossible to identify which visual field on this printout because it's totally opaque. Okay. However, if we see the full printout, definitely we'll know now which visual field. Can anyone tell me which visual field? Is it right or left? Yeah, right. And you are right, definitely right. Why? How do you know? Many things actually. So here, let's see. First of all, it's written in here in the printout. It's the right eye. This is one thing. And also here, if we enlarge this, there is a mark here, like a small triangle in Humphrey. It shows the blind spot location. So since it is on the right side of the printout, so this is the right visual field. And also the empty space here. Empty space here represents the blind spot, and even in the probability values, empty space here or rectangular. So many things actually show the side. The message here is whenever you are commenting on the visual field, don't forget to mention which visual field, okay? So there is some basic points at the beginning, like which visual field, is it reliable or not, before you jump into the defect itself or describing the defect. Again, still in the first question, catch me if you can. What is the blind spot? I need an answer because this is important, okay? What is the blind spot? Tell me. No blind spot. Why? There is no optic nerve? Why there is no blind spot?
This is because this is 10
Yeah,
degrees. That's why.
Yeah, that's why. Yeah, because this is as the physics program is just 10 degrees on each side of the fixation point, and we know that the blind spot, in order to be mapped, it should be like more than 10, like around 15 degrees. So it's impossible to know which visual field from this printout because it's only limited to the central 10 degrees around the fixation point. Okay, now I want to tell me in the chat the program and the side, right or left. So start with this one. Right or left visual field and name the program. Yeah, it's left and the program. So I'm going to show you the first answer because in order to save time. Yeah, exactly. We have 30 degrees here, but 24 degree here. So this is actually called 24, yeah, -2 program, and this is left visual field. The middle, right or left, and the program. Yeah, right. Yeah, 32, exactly. The last one here. Yeah, it's 10 and enabled to say the blind spot. And we usually order this visual field in advanced glaucoma case in order to meticulously map the central remaining area, and sometimes we increase the size of the stimulus, okay? So again, whenever the examiner gives you a visual printout, field printout, you have to say some points at the beginning before jumping into describing the visual field defect. Which visual field, I mean, the program, the type of the perimetry itself, is it reliable or not, and so on. Okay, we're still in this question, catch me if you can. What is a blind spot? Someone said left. Do you agree? Okay, let's zoom in a little bit. So here, actually, this is a visual field, and it looks strange a bit, right? For example, it's mapping the visual field up to 75 degrees on each side of the fixation. So in total, it's like 150 degrees in total, horizontally. And vertically, from 30, I think, to 60, or from 40 to 60, so we have 10 degrees vertically. This is huge, okay? Do you have any idea? Actually, according to candid experiences, there was a question regarding this visual field. In one of the experiences, the candidate was given such a printout. And this kind of printout has a name. This visual field has a name. Okay. What we call this visual field, by the way? Okay, so is it possible to have like 75 degrees nasally and temporally the same like this? Normally, the nasal field is very limited, so let's give you a clue. Do you think this is a monocular visual field? Yeah, binocular visual field. Yes, exactly. And it has a name. Okay. Generally speaking, visual field testing should be monocular. Each eye is tested separately, like visual acuity. But under certain conditions, we sometimes order binocular testing. So we have something called binocular visual acuity testing. We have something called binocular visual field testing. And actually, for the sake of time, this is a full printout of something required in this. Any idea? So DVLA is Driver and Vehicle Licensing Agency. And this is actually, if we enlarge this, yeah, someone write in the chat, let's see. Yeah, Esterman, yeah, exactly, Esterman. And sometimes they ask about this visual field. Esterman binocular or binocular functional test, okay? So make sure to read up about this test because it's there in the previous candidate experiences. So there is no blind spot because when we mapping the both eyes open, there is no blind spot because there is masking of the blind spot. So in order to map the blind spot, it should be tested monocularly. Okay, it should be tested monocularly. So what is the blind spot in Esterman? There is no blind spot because this is a binocular visual field. This is the answer. Okay. Yeah. Catch me if you can. This is probably the last one in this set of questions. What is the blind spot? Why there is no blind spot? Because, yeah, what is the name of this charting? Amsler. Okay, so how many degrees are assessed by Amsler? How many degrees visual fields? 10 degrees. Is it the central 10 degrees or 10 degrees around fixation, like on each side on fixation point? Yeah. Someone said 10 and someone said 20. Okay, so both are correct according to the continuation of your answer. If you say the central 20 degrees, it's correct from here to here. So 20 degrees, central 20 degrees. But if you want to say 10 degrees, you have to say 10 degrees around the fixation point. So 10 degrees from the fixation point here, 10 degrees from the fixation point here, and 10 degrees from the fixation point here. And of course, as we are mapping the center 20 degrees, there is no blind spot. All right, so we're done with the first question. I hope you enjoyed it, and let's summarize. So sometimes we can't find the blind spot if we are testing before the appearance of blind spot, like 10 degrees from the fixation point, for example. If we have extensive loss of the visual field, okay, so the blind spot actually is not visible when we are talking about the gray tone printout, or when we test both eyes open, okay, because the blind spot is masked by the other normal visual field areas. All right. Let's move to the next one, a harder one. Okay, so it's centered around the chiasm. So we call it chiasm, and in some books they mention chiasma, but chiasm is more accurate. So we used the chat a lot, okay, in the previous question. This time to unmute, okay, and I need someone to volunteer to answer this question. The first one is very simple. Do you think this guy is handsome? Okay, who would like to volunteer? So the first question is a bit easy.
Actually, this is AI, so we don't know.
No, I'm asking in general. This is an AI generated, yeah. But do you think he is handsome? A handsome guy?
Yeah, look like.
Yeah. So do you agree? Okay, that's nice. I agree too. This is not the only part of the question. Now, this handsome guy, for some cause, after a couple of years, his appearance unfortunately became like this.
Yes.
Is he still handsome?
No.
Why?
His features become coarse and look like some disturbance has occurred, some hormonal imbalance.
Yes. Now give me a more specific answer. What hormonal imbalance you are talking about?
I'm talking about some like pituitary tumor that is leading to the growth hormone secretion that could lead to gigantism and acromegaly.
Okay. All right. So you mentioned two terms right now. You mentioned acromegaly and gigantism. So which one? So because this is one entity and this is another entity.
This acromegaly.
What's the difference?
When it appear before the bone growth occurs, this can lead to in the kids, they lead to the gigantism.
Yes,
While
exactly.
in adults, it leads to acromegaly.
Yes. All right. So let's see the next slide. Because sometimes they ask about the hormonal abnormalities and hypersecretion of pituitary gland. So make sure to know everything. And as you said, it's collectively we can call it coarse features.
Coarse feature.
Yeah, prominent ridges, changes in the hair. Yeah, the chin is more prominent, lips are thicker, mouth appear wider. Yeah, many things. All right. So what is the expected visual field?
Yeah, it depends upon the where is the pressure on the optic jaws. Usually, it leads to bitemporal hemianopia.
Okay. Suppose it is not incomplete yet. So which is more affected, the upper temporal or the lower temporal?
Upper temporal will be involved first.
Why?
Because the lower nasal fibers are involved first. That's why.
Okay, excellent. You're amazing. Thank you. And by the way, this is called prognathism as a sign. So would you rather having, God forbid, secreting pituitary tumor or non-secreting one?
Yes, ma'am. Secretory that could lead to the hormonal imbalance, and non-secretory, they are usually macroadenomas. They lead to the pressure effects
Okay, so
mostly.
I'm asking you, would you rather having which one?
Again, I can understand your question, please.
Okay, so if you have a choice between having secreting pituitary tumor or non-secreting one, which one you prefer?
You mean which one is easy to manage?
Not
Yeah.
managed,
So
but which one is discovered first?
discovered first, it would be secretory.
Okay, so yeah,
Yes.
so generally speaking, because of the hormonal manifestation,
Yeah.
this balance,
Yes.
it's easy picked. Okay,
Yes.
so it's easy picked before the visual field becomes extensive or even appear. But
Yes.
for non-secreting one, they usually presented
Mm.
late with the advanced visual field effects.
Yes. It's until they exert a pressure effects. So
Yes,
that would present that. Yes.
yes. And when it comes to secreting, it's more discovered earlier in women than in men because women have menstruation and they can notice disturbance in menstruation. All right,
Yes.
nice. Okay, thank you.
Thank you, ma'am. Thank you so much.
You're welcome. You did great, yeah. So, yeah, you have to know a little bit about the anatomy and physiology of the pituitary gland. Yeah. We have anterior lobe, posterior lobe, intermediate lobe, and some hormones. You need to know the manifestation of prolactinoma and increased growth hormone. We can categorize the manifestations into 3 categories. Practice answering this in an organized manner. So we have ophthalmic manifestations, endocrine or endocrine manifestations, and systemic neuro manifestations. And they ask about all of these. Don't only study the ophthalmic manifestations, you have to know a little bit about endocrine and the neuro or systemic manifestations as well. Okay. When it comes to ophthalmic manifestations, we have 2 things here. I'm gonna discuss right now. Post-fixation blindness. You see this? Post-fixation blindness or scotoma and heminopic slip. I wrote them under the heading of symptoms, but usually it's not accurate to say under the heading of symptoms because a symptom is all about patient's own words. So the patient won't say, I have a post-fixation blindness. They usually describe it differently, okay? So I'm gonna talk about what's the meaning of post-fixation blindness. So pay attention. They ask about these according to past experiences. And we can understand the meaning. We have to understand the meaning in order not to forget these findings. Now, this is the right eye, okay? I'm pointing at the right eye. Again, what I'm saying right now based on what we covered in the previous classes. So the right eye, suppose it is fixating on this star, okay? You see this star? You see the black marking here. So the right eye is fixating on this area. So what is the visual field, the nasal visual field of the right eye? The one in red, which is intact, okay? Because we are talking about bitemporal heminopia in pituitary adenoma. So this in red, the intact nasal visual field of the right eye, okay? And where is the temporal field? This field, which is affected. So I'm making lines here. All this part is, imagine it's black, it's affected. So to repeat again, this is the right eye. This is the right eye, fixating here. So this area is the nasal field, which is intact, and all this area is the temporal field which is affected in our case by temporal heminopia. Now, let's move to the left eye. This is the left eye. Again, it fixates on the star in this fixation point. So the nasal field, which is intact, is in blue, overlaps with the affected temporal field of the right eye, but not all the temporal field, okay? So remember, this is in blue, the intact nasal field of the left eye overlaps part of the temporal field of the right eye, the affected temporal field of the right eye, okay? So this area is quite good. This area is quite good because it is served by the intact nasal field of the left eye. So this means, back to the right eye, this temporal crescent is totally black, because it is not overlapped by the nasal field of the left eye, and also this black triangle here. I will mark it in yellow. Okay? To sum up, whenever the patient fixates on the star here, there is an area totally black posterior to the fixation point. And that's why it is written here, complete blindness behind the fixation in this area, marked in black. This. Now I'm marking it in yellow. So this is actually the meaning of post-fixation scotoma. So whenever the patient fixates on something, and usually during close work, they have an issue with tracking lines and reading because we need to have an intact visual field in front and posterior to the fixation point. So again, in bitemporal hemianopia, despite the fact that the temporal field of the right eye is affected, but there is part served by the intact nasal field of the left eye. So the end result, we have a blind temporal field because this area is served monocularly, okay, and part here. And this part actually is dark. We call it post-fixation scotoma or blindness. If I repeat the same on the left eye, it's the same because the left eye has a temporal field defect and intact nasal field here. And the temporal field, this area is served by the intact nasal field of the right eye. So this is somehow okay, but we still have a temporal field, temporal crescent blind, and again, the central area here. Okay, this is from Kanisky, and actually it's added in the new edition. It shows you how this happens more with close work, because when you are looking at near, your eyes are converging. So the overlapping blind area becomes larger, okay? So how would the patient would describe this finding? They may say, I have an issue with reading, with close work, words disappear, things along these lines. Okay, and that's why I wrote post-fixation blindness under the heading of symptoms, although it's a medical term. Let's move to the next one. So I want you to understand it instead of just memorizing these terms, because you can understand it easily. The next one is something called hemifield slip. In some books, they call it non-phoretic diplopia, and I'm going to explain why it is called so. So what's the meaning of hemifield slip? Now, look again to our case. We are talking about bitemporal hemianopia. Don't forget that we are talking about pituitary adenoma that results in typical bitemporal hemianopia. So as you can see here, I removed the temporal crescent from each field, the right field and left field. So what we have right now? We have the intact nasal field of the left eye on the right side, okay? And the intact nasal field of the right eye on the left side. So for patients with bitemporal hemianopia, the remaining fields are what? Nasal fields, but it is like in opposite direction, because the right side of the viewing or the right side of the environment is served by the nasal field of the left eye, okay? And the left side of any scenery is served by the intact nasal field of the right eye. This is really important. Again, this is basic, something basic. We discussed it before in the first class on this series, on the class 15. So as shown on the diagram, suppose you are looking at the scenery. Let's say from here to here, there is a scenery, okay? The left side of the scenery is served by the intact nasal field of the right eye. And the right side of the scenery is served by the intact nasal field of the left eye, the contralateral eye, in other words. Now, imagine, sometimes we have something called phoria, okay? Pay attention to what I'm saying right now. Most of the time we have something called phoria. Phoria means latent squint, latent strabismus. We have tendency to deviate, but we are compensating. Okay, so our brains are able to compensate this phoria and to make some kind of alignment under binocular condition. So now imagine a patient, okay, with exophoria. Exophoria. What's the meaning of exophoria? Their eyes have the tendency to deviate out. Exophoria. Their eyes have the tendency to deviate out. If the patient develops bitemporal hypnopia, actually this might lead to decompensation of exophoria into something called exotropia. And this is the abbreviated form for exotropia, like manifest divergent squint or strabismus. Because of visual field defects, this might trigger decompensation. So instead of having exophoria, they decompensate into exotropia, into manifest divergent squint. Of course, one eye will diverge. Let's draw the right eye diverge. Let's imagine this right eye will divert outward like this. When this eye divert outward, it will take the intact visual field, the one in red, it will move like here. So what is the end result? There will be an overlap between the intact nasal field of the left eye with the intact nasal field of the right eye. Did you get it? Yes, okay. One more time. This eye will decompensate and deviate outward. The visual field, its visual field will move also in this direction. So the red triangle here will overlap with the blue triangle here. And that's why in this diagram, you see in exotropia, there is overlapping of the nasal fields. So this explains this part of the diagram, overlapping of the nasal fields, because patients with bitemporal hypnopia, they only have nasal fields. So they have overlapping of nasal fields. Back again to this photo. If someone has esophoria, and this is, by the way, the abbreviation for esophoria, just E, esophoria, okay? Having bitemporal defect will allow this phoria to manifest and becomes esotropia. If patient with esophoria developed bitemporal hypnopia, it may become manifest and becomes esotropia. So again, let's make the drawing on this right eye. So this eye will deviate inward, okay? And this red triangle will move actually in the same direction. So the nasal field stay away from the other nasal field. And this the schematic representation represents the appearance in esotropia. So the nasal fields are now separated by something called scotoma here in the middle. Again, if this eye, right eye, moves inward, its nasal field will move in the same direction. There will be a gap between the intact nasal field of the left eye and the intact nasal field of the right eye, as in this diagram. In case of hypertropia, there was like misalignment vertically. Now, after this simplified explanation of what hemifield slip or hemianopic slip actually means, let's look at how a patient might describe this phenomenon. All right. So according to an article written by experts in the field on iWikipedia, I'll share the link in the video description. We can better understand the patient's visual experience in these cases. So let's look at the left side of this slide here. In case of esotropia or inward deviation, we said before the nasal visual fields are separated by a central scotoma, as shown here in the image above. So suppose the patient is looking at this cat. Part of the image is missing. So how would the patient describe this? Let's zoom in. They would likely say that something is missing. Like here, part of the cat may disappear. So there is only one eye here. The leg is incomplete because a portion of the image falls within the scotoma. In contrast, in case of exodeviation, we said there is an overlap of the nasal visual fields here. So when looking at the same object, this overlap can create a kind of image doubling. So as you can see here, the patient may report double vision, which is not the typical form of diplopia, as we know, because the typical form of diplopia is that the full image is duplicated. All right, so, and that's why it is called, sometimes in some references, they call hemislip phenomena as non-paretic diplopia because of this situation. And of course, in either case, there is no paralysis of the muscle. This image also illustrates when the patient might see in cases of vertical misalignment, as you can see. So if you'd like to explore this topic further, you can refer to that website, to this article on iWikipedia under the heading of hemifield slide. So overall, this highlights how important intact visual fields are. Under normal binocular conditions with normal visual fields, there must be an overlap between the nasal field of one eye and the temporal field of the other eye. This is very essential for maintaining single vision and preserving orthophoria, or at least keep any latent phoria compensated. However, when there is severe bilateral visual field loss, as in our case, complete by temporal hemianopia, this balance is disturbed. So, as a result, a previously compensated phoria may decompensate into atropia, leading to significant visual symptoms for the patient. Again, and that's why I wrote post-fixation blindness and hemianopic slip or hemifield slip under the heading of symptoms, because here patients experience visual symptoms. So we are done with this. And sometimes hemianopic slip, they call it non-paretic diplopia, because patients with pituitary adenoma may develop something called paretic diplopia. One more question here. I just mentioned that in some cases of pituitary adenoma, they may develop paretic diplopia. What is the mechanism? How can pituitary adenoma cause paralytic squint and diplopia? Is it possible?
If it is raised ICP and pressing on 6 now?
Yeah, but this is very rare. So very rare that pituitary adenoma is like huge enough to obstruct the CSF circulation and causes papilledema. It's reported, but it's very rare. There's another mechanism, but it's good start. Yeah, cavernous sinus, because yeah, it maybe expand and compress cavernous sinus on each side, and you know we have 3 and 4 and 6 in the cavernous sinus. Excellent. And sometimes you call it, you see here, the efferent, sometimes in some books you call it the efferent manifestations of pituitary adenoma. If it causes cavernous sinus syndrome, this is called efferent manifestation. Okay, so back to pituitary adenoma. We talked about the visual field defects, which is typical, the bitemporal hemianopia, more superior. How about fundus examination? So if we go back here to the manifestation, we have here fundus. So we have some papilledema, as you mentioned, but it's very rare. The fundus may be normal, and there might be some kind of specific atrophy. Can anyone tell me about what is the appearance of atrophy in case of pituitary adenoma?
Bow tie pattern.
Yes. Why? Oh, before you answer why, so what's the meaning of bow tie? This is an analogy. Okay, so suppose someone doesn't know what's the meaning of bow tie. So can you explain what's the meaning of bow tie optic atrophy?
Bow tie pattern mean like on both sides
Oh,
there is like on paracentral atrophy, like in the shape of bow tie. I don't know how to explain this.
okay. So we have thinning and pallor and a bow tie configuration in this area and in this area. Why?
That's why we are learning from you. We are here.
Okay. All right, nice. All right. So yeah, so in the exam, if you are not sure that you don't know the answer at all, just let the examiner know in order to move to another question, okay, to save time. Yes, exactly. As someone mentioned in the chat. So remember, we have like damage or affection to the crossing fibers in chiasmal compression. So pituitary adenoma results in chiasmal compression, okay? In the chiasma, we have the crossing nasal fibers. So these fibers, this is number one. Fibers comes from the nasal retina will cross in the chiasm, okay? And the chiasm is compressed by pituitary adenoma, okay? And also we have the nasal macular fibers, which are this one. So the fibers in red are affected by chiasmal compression because they are crossing in the chiasm. So remember, in chiasm, we have crossing of the nasal fibers, whether that come from the nasal retina or this pupillar macular bundle that comes from the nasal macula, okay? So the new retinal rim in this area and this area will become thin and pale, all right? In this illustration, in my illustration here, I'm marking the nasal in yellow because this is the affected parts in chiasmal compression. This is called bow tie configuration. So here N and N, let's go back here, and we call it this T and T. Up and down is called T and T because these fibers comes from the temporal retina and also the temporal macula. So this is a labeling of the new retinal rim according to the fibers. T above and T below, N nasally and N temporally, okay? Because we said before, the line of fixation is the landmark here. Here it's considered nasal, this area is considered nasal, and this area is considered temporal. So we may find this bow tie in pituitary adenoma in both eyes, okay, in both eyes. Again, this is bitemporal hemianopia, more advanced on the upper in case of pituitary adenoma. And this is the anatomical explanation. I want you to remember this. The optic chiasm is somehow, the direction is like this, moving up, like it's somehow oblique anatomically. Remember this, please, in order to avoid confusion in the future, okay? So this is anterior. Okay, this is anterior and this is posterior. So if you want to draw the section of the optic chiasm, draw it like this. Make it oblique upward, toward and posteriorly, like this. This is anterior and this is posterior. All right? This is a very commonly asked question, by the way. And also, you have to know that fibers come from the lower retina all the way are located lower. So here, if I draw fibers here, this actually carries visual information from the lower retina. So this is lower retina, okay? And of course, you have to say lower nasal because we are talking about the chiasm. So chiasm, we will find nasal fibers. And that's why it's really important to say low, okay? So the lower fibers or the fiber carries information from the lower retina is located lower along the visual pathway, okay? Except for the lateral geniculate body. and from upper retina are located up in the chiasm. Remember this. So in chiasm, we will find nasal fibers. The lower is located lower, and the upper is located upper. Okay? Also remember, because of the configuration of the chiasm obliquely upward, we say that the lower nasal fiber are located lower and anterior, and the upper nasal fiber are located above and posterior. We are adding some information right now. So the lower nasal fibers are located lower and anterior and are first affected by the pituitary adenome. And the upper nasal fibers are located upper and posteriorly. And we have a tumor here, an important tumor here called craniopharyngioma. First compresses these fibers. And this is one of the childhood tumors. It may result in bitemporal hemanopia, but affecting first the inferior visual field, inferior temporal visual field. Why affecting the inferior visual temporal fields? Because it compresses the upper nasal. Okay, so the upper nasal fibers serve the lower visual field, the lower temporal field. Okay, the inverse relationship that we all know. If you like mnemonics, so you can remember this ABC. So we have C, the craniopharyngioma, compresses the chiasm from above and behind. Okay, so one more thing here. The lower and upper visual information respect the anatomy. So the lower stays lower and the upper stays upper along the visual pathways, except for the lateral geniculate body. Okay, remember this, we'll mention it again towards the end of the class. So this photo is really important, because sometimes they ask a simple like anatomical question, where is the lower nasal fiber, or what are the fibers located in the chiasm, for example. Okay. A patient with bitemporal hemanopia, sometimes they describe the defect by saying, they may say, as if we are wearing a blinker, like this horse, for example. The temporal field is obstructed, is not there, okay? Because of this shield, horses can't see the temporal visual fields. Now I have a question, because I talked a lot. What are the other causes of bitemporal hemanopia, other than we mentioned? Other causes for bitemporal hemanopia.
Bilateral dermatoclasis.
Yeah, exactly. Yeah, this one thing. Because of dermatochalasis or chalasis is sometimes more extensive temporally, it results in temporal visual field in each eye. So the cause must be bilateral, okay? So the differential diagnosis of bitemporal hemanopia. We have also bilateral nasal retinoschisis and retinitis pigmentosa, or bilateral tilted discs and coloboma, and you should say bilateral. Plus, it could be something functional, non-physiological visual loss, or nasal photocoagulation, okay. But it should be bilateral and nasal. Nasal when we are describing something related to the posterior segment. But if we are describing a lesion anterior, it should be in the same direction. It should be lesions in the temporal aspects, because the inverse relationship we talked about occurs after the nodal point. Again, so differential diagnosis of bitemporal hemanopia if we have a lesion in the nasal retina, okay? Because this is an inverse relationship between the retina and visual field. But if we're talking about something anterior, like in the cornea or in the eyelid, there is no inverse relationship. If we have a ptosis, for example, blepharoptosis, it will cause superior visual field defect. There is no inverse relationship here. Yeah, someone mentioned something interesting. Yeah, lacrimal gland. Yeah, unlucky patient with bilateral lacrimal gland. Yeah, maybe. By the way, all the other causes of bitemporal hemanopia don't respect the vertical meridian. All right, this is a very important differentiating point. Now, another question. We're still, by the way, in the second set of questions. Now, let's move on to this one, this diagram. Can anyone comment on this one? What's 1 and 2 and 3? What does this diagram show? Say something, anything. It's from, I think it's from Kanitsky, yeah, exactly. Now, which one is normal? Normal placement of the chiasm? Yeah, right, yeah, you corrected yourself, thank you. All right, so here. So the fixed structure is the sella tursicus. This is a fixed structure with the gland inside, okay? But we call prefixed or postfixed according to the chiasm. So prefixed the chiasm is more anterior and postfixed the chiasm is more posterior. And that's why the visual field defects caused by pituitary adenoma, for example, in this case, in the postfixed, it might also compress the optic nerve. This is the optic nerve, the junction between the optic nerve and chiasm. And in such a case, what is the visual field defect? What is the reported visual field defect if a pituitary adenoma compresses the junction between the optic nerve and the chiasm? What we call
Junctional
this?
scotoma.
Yeah, junctional scotoma. Can you describe it?
There will be infronasal fibers which will cross from the, suppose if it is from the right eye, it goes to the, instead of going to the left optic tract, it will go and into the left optic nerve and then goes to the left side of the optic tract. So whenever the optic nerve is distal part of this proximal part of the optic nerve is compressed, like in pituitary adenoma, there can be compression of the infronasal fiber. So supratemporal field defect along with the blindness of that eye can occur.
Okay, nice. So again, here, what is the postfixed? Yeah. So whenever we have a pituitary adenoma here, it may compress optic nerve, and it creates a junctional scotoma. So back again to you, doctor. So can you help me in drawing the visual field on this eye? Oh, sorry about this drawing. So I want to demonstrate junctional scotoma. So suppose there's a compression here.
Yes, ma'am. So the compression, if the compression is in the left side, suppose that is the left eye, then the total scrotum of the left eye with the supratemporal defect on the right eye.
So you are describing, this is a nasal fibers, right? Let's have a
Yes,
diagram.
ma'am.
Yeah.
Yeah, nasal fibers that will grow to the opposite optic nerve, the Willebrand's knee.
Yeah.
So there will be compression.
And you
The
said
opposite eye will have the supratemporal field defects.
yes. So if we draw this eye and the visual field of this eye, so we have here what we have here in this eye, the visual field of this eye, the left side, central scotoma, because of affection of the optic nerve, and because of the affection of the inferior nasal fibers here. So we have superior temporal defect here. And this is called junctional
Ma'am,
scotoma.
will there be total blindness on that side? Because the nasal fibers and as well as the temporal fibers both are being compressed.
Yeah, I see what you're saying. But generally speaking, visual field defects can vary in severity. So visual field defects depend on the location of the mass or the compression, so the site of compression, and also the severity. The degree of insult also varies in cases of optic nerve compression. For example, in this slide, it shows junctional scotoma. So as you can see here, the dark circle here, it means central scotoma, and this is the left eye, okay? And you see the indentation of isopters in the right visual field. This means superior temporal defect. And here is the corresponding Humphrey. You see this decreased sensitivity in the upper temporal, and here some scattered area of diminished sensitivity. So this is one form of presentation. The insult to the optic nerve results in just central scotoma, and the patient presents with diminished visual acuity. So the importance of knowing such a case that you need to do confrontation visual field test, and sometimes you may order automated perimetry if you have a case of unexplained diminution of vision in one eye. because this might point to compression at the junction between the optic nerve and chiasm. And this is, by the way, from the American Academy, and this is a neuroimaging MRI of the previous case. So as you can see here, if we look at the MRI, this is the right side and this is the left side. The mass here is compressing the distal part of the optic nerve. But here, as you see, if I enlarge this, the cross-section of the optic nerve is quite good here. So there is no compression on the right optic nerve, but there is compression on the distal part of the optic nerve. In another section here, it shows the optic chiasm. So the mass somehow doesn't compress the chiasm, doesn't compress the optic chiasm, but it compresses the junction between the optic chiasm and distal part of the optic nerve. Okay, again, this is the right side and this is the left side of the MRI. This is a severe case of junction stoma, as you described earlier. Yeah, total blindness, or maybe the field is almost lost in the left eye. This is junction stoma, and also because of the compression of the optic nerve at its junction with the chiasm. And why I know this is the junction between the left optic nerve and the chiasm, because there is superior temporal field effect in the other eye. So it's another case of junctional scotoma. Another case of junction stoma, severe case, because you see this fits your description, and the insult to the left optic nerve is severe. And here is the superior temporal defect. And that's why, because of the variation in the severity, if we see this diagram, for example, here, number 2, this is the junction scotoma. As you can see, this marking at the junction between the chiasm and the right optic nerve, okay? You see here, it is right visual field is depicted totally black, as your description, and you have junction scotoma on the other eye. But in this diagram, at the second position here, the insult to the right optic nerve is depicted only by drawing a central scotoma. Okay. Another difference between the two diagrams, this only shows the central field, okay, but this is like mapping of the entire visual field. The same applies for the first case at number 1, for example. The insult to the optic nerve may be total, severe insult, like in case of optic nerve avulsion, for example. So we expect blindness on the right eye, result in monocular visual field defect, but it could be something like optic neuritis, resulting in just central scotoma. Overall, this illustrates how visual field defects vary according to the severity and location of the lesion. To summarize junctional stoma, you need to understand the anatomical basis, specifically the course of the lower here, you see, the inferior nasal fibers. So these inferior nasal fibers are located in the anterior part of the optic chiasm, as I mentioned earlier. And before crossing into the contralateral optic tract, these fibers take a short course within the contralateral optic nerve, forming what's known as the anterior knee of Willebrand. Therefore, if there is a lesion at this junction, it will produce visual field defects in the ipsilateral optic nerve. In addition, there will be a characteristic superior temporal defect in the contralateral eye. So junctional stoma refers to compression of the optic nerve at its junction with the optic chiasm. The visual field defect is variable, ranging from central to more generalized visual field loss in the ipsilateral side and contralateral. Superior temporal scotoma due to involving of the crossing lower nasal fibers in the anterior knee of Willebrand. I hope it's clear now. So again, to sum up, we have something called chiasmal compression or chiasmal syndrome. Chiasm might be compressed from something coming from below the pituitary adenoma, or something from above, craniopharyngioma, but we have other causes for chiasmal syndrome, and it's written in Kanski. And also, when it comes to pituitary adenoma, it results in chiasmal compression, but it also may compress the surrounding structures like the cavernous sinus, and it might compress itself and causes dysfunction or hyposecretion of the pituitary gland. So be aware of hyposecretion. This is from Showa website. As you can see here, the most common cases in visual field station by temporal hemianopia. Also look for evidence of pituitary abnormalities such as acromegaly. So this is an example of hypersecretion of growth hormone in adulthood, or hypopituitarism, because the tumor compresses the surrounding normal tissue, resulting in decreased secretion of the gland. So you make sure to know a little bit about hyposecretion as well. Okay, last question in this set of questions. What this diagram shows.
Transsphenoidal surgery.
Yes, transsphenoidal, because we are endoscopically through the sphenoid sinus, they remove the enlarged adenoma. Because according to the experiences, they ask also about how do you manage a case. Okay, so you have to know a little bit about the hormonal treatment and the surgery. Just the name of the surgery, transsphenoidal hypophysectomy. Okay, endoscopic transnasal transsphenoidal surgery. Okay, and the case should be followed post-surgery to document improvement of visual field or resistant to treatment. As you can see on this slide, it highlights the importance of following up the case after surgery and performing visual field perimetry. On the left side, this is the pre-op. It shows a case of bitemporal hemianopia, incomplete bitemporal hemianopia, more advanced on the left side. And also the fundus examination shows bilateral optic atrophy, bow tie configuration. If we look at the OCT, you will notice that the thinning of the neuroretinal rim is more advanced in the left eye, many areas in red here. Okay. This is a post-op, and as you can see, the right eye shows complete recovery, whereas the left eye still has some residual damage because it was more severely affected preoperatively. So again, this demonstrates how OCT can help us document the case. It is also suggested that based on the OCT, we can predict the visual outcome according to the thickness of the neurofiber layer. Okay, so you see this symbol, you have to work on your own and read about pituitary adenoma in detail because this is a high yield question. They ask also about pituitary apoplexy and finally empty cell syndrome. Now try to read aloud this slide and study this slide. And here is the imaging of pituitary apoplexy. Now this is MCQ centered around such a case. This is the correct answer. And here is the discussion. For empty cell syndrome, again, read aloud this slide and try to learn a bit about this syndrome. Because according to one experience, there was a question about empty cell syndrome. I'm leaving this slide for a couple of minutes to read this experience and try to imagine that you were the candidate and try to prepare your answers for every question. Also here, try to avoid saying pituitary adenocarcinoma. We usually say adenoma Because when it comes to brain tumors, it's a space-occupying lesion. It's dangerous if they left untreated, okay? So it doesn't really matter to classify adenoma or adenocarcinoma. This is something we can know after excision of the tumor and biopsy. And yeah, we can know somehow pre-operative from the aggressive course. But generally speaking, we usually say pituitary adenomas. And as you can see, the candidate was asked about post-fixation blindness and hemifield slip that we discussed earlier. Yeah, we're done with the two big questions, and the remaining questions, I guess, will be easier. The third question: name this boy and name this point. It's an exercise to observing power and correlation.
Optic chiasma, nasal fiber crossing and going to the opposite side.
Any other thought? No, see the landmark. There is some road landmarks here, signpost. See this one? Yes.
Edinger Westphal nucleus.
We have two friends here, started the journey together, but at some point they split off. One went to the Edinger Westphal nucleus. So what we call this, what's the name of this boy?
Pupillary pathway?
Yeah,
Light?
yeah, pupillary motor fibers, exactly. So let's see here. So the point of splitting is just before the lateral geniculate body, not the chiasm, okay? So here, let's see the animation here. So we have also pupillary motor fibers, temporal, past and crossed, and also we have the crossed pupillary motor fibers, crossed at the chiasm, and they pass with the visual fibers in the optic tract, but just before the lateral geniculate body, they leave this and pass to the pretectal nucleus, okay? And then the Edinger Westphal nucleus and the remaining pupillary pathway, okay? I mean by the boy, the pupillary motor fibers. And the point is just before the lateral geniculate body. This is really important. Why? This is an anatomical fact, but what is the clinical significance of knowing this?
Pupillary fibers don't relay in lateral geniculate body. Just directly goes to the pretectal nucleus.
How would this help us in localizing a lesion along the visual pathways?
Presence or absence of RFPD?
Yeah, so in other words, if we have a lesion here, or the occipital cortex, the pupils are normal, are fine. So it helps in localization somehow, because pupil examination is part of our assessment. If we have a lesion here, 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 pupils are normal because they don't belong to this area, okay? But if we have lesion here, 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 pupils examination may show sign, especially, of course, in optic nerve. Okay, I need someone to read aloud this slide slowly. We will talk about this in detail when the time comes to discuss pupil examination. I hope in the near future. So someone just read aloud this slide. So the questions asked, how does pupil examination help in localizing a lesion along the visual pathways? Yeah, someone, please.
Visual field defects in RAPD. RAPD could be present if the lesion is along the afferent pupillary pathway before lateral geniculate ganglion. The RAPD will be found in the eye contralateral to the side of the lesion because 54% of the nasal fiber crosses to the contralateral tract and 47% of the temporal fiber remain ipsilateral. However, a RAPD would not be present when the lesions are beyond the lateral geniculate nucleus body because the pupillary fibers are not involved.
Okay, so clear to everyone? So one more thing. So if we have an optic tract lesion here, the RPD is expected to be on this eye, the contralateral eye, because most of fibers are coming from this eye, the contralateral eye. Okay, so this actually is one of the MCQs. If we have a right optic tract, the RPD will be on the left eye, the left pupil. Read the next one, next slide. Yeah, please continue.
A lesion confined to the optic tract may cause incongruous homonymous field defect and RAPD contralateral to the optic tract lesion. Why? Answer. A lesion of right optic tract, affection of right uncrossed temporal fibers and crossed left nasal fibers, and as crossed nasal fibers are more than 54% temporal fibers, so the insult is pronounced for the left eye and it shows left RAPD.
Okay, thank you. I think everything is clear now. Here's a question. Which optic tract is affected according to the visual field, to this visual field? This is the right visual field and this is the left visual field.
Left.
Yeah, so this is actually, yeah, all right, homonymous hymenopia, incongruous, right? Now, the follow-up question here. We have some atrophy in each eye. So this is the optic disc of one eye and this is the optic disc of the other eye. Tell me which optic disc belongs to each eye. So the things in yellow shows atrophy. So in one eye we have both eye atrophy and the other eye we have upper and lower atrophy. Is this the optic disc of the right eye or the left eye? And also here.
Right eye is nasal thinning and left is temporal thinning.
Say it again.
Because right eye has right temporal field defect, so
Okay,
nasal fibers probably involved.
let's think step by step. So in our case, we have a left optic tract. Okay, left. See this marking, the left tract lesion here, and that's why we have
Okay.
right homonymous hymenopia. Okay,
Hymenopia,
so
yeah.
when we have a left optic tract, we have what? The nasal of the right.
Nasal fibers of right eye and the
So
temporal fibers of
the
the left
nasal
eye.
fiber of the right eye. So this is the optic disc of the right eye. Is that what you are
Okay,
saying? Okay. All right. So let's see. Again, for the others. So the optic tract is affected here. The optic tract, the left optic tract here. So what we have in left optic tract, the nasal of the right eye. So what is the nasal? This one and this one, atrophied. Okay. So this is the optic disc of the right eye. And back to the left optic tract, we have the temporal fibers. So what is the temporal fibers represented in the optic disc? Up and down. We talked about this before. Okay. So this is how the fundus looks like in a classic case or like typical case. And that's why in optic tract lesion, we have both eye in one eye. Okay. In the contralateral eye and affection of the upper and lower on the same side. And it's written in Kanensky, I believe. Every station along the visual pathway, you have to know the manifestations, like the findings. For example, if we have a lesion optic tract, the visual field appearance, pupils examination, fundi examination, talking about atrophy, other neurological manifestation. So you have to know this because this is a very commonly asked question to localize a lesion. So you have to know the findings at each part, optic nerve, optic chiasm, tract, and so on and so forth. The fourth question describes the finding. For such a question, if suppose you don't know the answer, just describe what you are seeing. Actually, this is not a real visual field. It's, I believe it's a schematic representation. Okay, so at least you can describe what findings. There is a visual field effect. Can anyone volunteer or shall I proceed? I'm going to proceed for the sake of time. So we have visual field defects that respect the vertical meridian. So we are talking about neurological disorder. And it is on the right side. So it seems like as if it is like right homonymous hymenopia, but like with sparing the central part. And this visual field actually points to lateral geniculate body affection. And it's called hourglass. Okay, hourglass. It's incomplete, but like half an hourglass. So any lesion after the chiasm will result in contralateral hemanopia. All right. So you need to say, since this is a right affection, right hemanopia, so the lateral geniculate body, which one is affected is the left, the contralateral side. And why this configuration? Because of the blood supply. All right. And this is called, by the way, sectorinopia. So in summary, the lateral geniculate body, okay, is supplied by two arteries, anterior choroidal artery and posterior choroidal artery. Actually, it is called lateral posterior choroidal artery, okay? In order to memorize the information. The central part, just imagine that whenever we talk about the central, like central vision, central visual field, we think of something posterior, something like posterior pool, okay? Whenever we talk about central vision or central field, we think of the posterior pool. So actually the central area is supplied by the posterior choroidal artery, the lateral posterior choroidal artery. This is a way to memorize. This is a kind of mnemonic. So this central sector is supplied by the lateral posterior choroidal artery. But the upper and lower sectors are supplied by the anterior choroidal artery. So in such case, a schematic representation, there is an obstruction or let's say stroke or infarction due to obstruction of the anterior choroidal artery. So, and that's why the field defect in the upper and lower. So we have something called homonymous quadruple sectorinopia. Quadruple, because this is like 4 quadrants, 1, 2, 3, 4, okay? But if we have affection of the lateral posterior choroidal artery, we will have the central sector affected. For example, in this schematic representation, this is called left homonymous quadruple sectorinopia due to affection of the posterior lateral choroidal artery. And this is a left homonymous quadruple sectorinopia due to affection of the right lateral geniculate nucleus due to obstruction of the anterior choroidal artery. I answered this question anyway. The next one, an easy one. Number 1 points at, this is from Kanisky, right? So what are these fibers? What we call these fibers?
Meyer's loops?
Yes. Really? It is a trap.
Temporal fibers.
Okay. So it's total opposite, right? So now try to say one answer. Is it temporal or parietal? Is it Meyer loop or parietal fibers? Or fibers in the parietal loop? Parietal. Okay. So is it anterior parietal or posterior parietal?
Looks like posterior parietal.
Okay. Doctor, pay attention, please. Focus. It seems you are hypoglycemic. Okay, so so let's see. So this is posterior. This is the tip of the occipital cortex. So this is posterior.
Anterior.
And this is anterior. So I'm pointing at this area. Okay, so according to Kanisky, like at B. Okay, so this is anterior parietal.
Okay.
So what we call these fibers? The name?
God no. Why?
No. You know. But the answer is hidden. Okay, so make it manifest. So remember, this is the lateral geniculate body. What we call the fibers after the lateral geniculate body? What we call it? According to the visual pathways, after relay in the lateral geniculate body, we call it what? The fibers, fanning fibers. Yeah,
radiation.
Optic radiation. So so simply we can say this is a optic radiation in the anterior parietal loop. Yeah, or we can say, as someone said here, parietal radiation. Okay, excellent.
Okay.
So what are the visual fields? The expected visual field if we have a lesion here.
So inferior quadrant anopia.
Yeah.
Because of
So you have to say contralateral, okay?
contralateral
Because
inferior quadrant.
the side is important. So again, remember the fact that I told you before, visual information from the upper retina stay upper. Parietal lobe is upper. So we'll find the fibers from the upper retina here. The visual information from the upper retina is here. So what is the expected visual field? The opposite, inverse. So it would be inferior quadrant anomia, as you said. All right, so let's answer this MCQ question. Read it aloud and answer it, please.
A 63-year-old right-handed man has an isolated infarct of the entire left parietal lobe. Which of the following would you least expect to find on examination? A right homonymous hemianopsia worse in the superior hemifield than in the inferior hemifield. B is acalculia. C is impaired optokinetic nystagmus with the tape going to on the left. D is right-left confusion. So left parietal lobe infarct. So least expect to find on examination. Optokinetic nystagmus will be there, ma'am.
Okay.
Definitely.
Okay. Okay.
Right hemianopsia will be there.
One second. You just answered this question and you told me that in parietal lobe lesion we have contralateral inferior quadrant anopia. You said this a few seconds ago, right?
Yes,
how about the first one?
Yeah, worse in the superior hemifield than in the inferior.
So this is the wrong answer. Okay?
Okay, ma'am.
So actually it's an easy question. All right? The other findings are true, by the way. Okay. Well, so, and that's why I told you earlier in the class, this is very confusing when it comes to strabismus and neuro. Very easy to mix up things, you know. So that's why you need to be focused a lot, okay? All right. By the way, what is the importance of mentioning that this patient is right-handed?
To see the dominant lobe.
Yeah, exactly. So now the infarction is in the dominant parietal lobe, right? Right or no?
Yes.
Yes, okay, right, correct. Okay, so there is a syndrome described when we have a lesion in the dominant left parietal lobe. What's the name of this syndrome? And it's written in Canis, I believe.
No, Gertzmann syndrome.
Yeah, Gertzmann syndrome. So what are the features of Gertzmann syndrome? Acalculia, agraphia, finger agnosia, and left to right disorientation. Okay, this is a component of Gertzmann syndrome, and it should be in the dominant hemisphere, as in our case, because the man is right-handed and the infarction in the left parietal lobe. Okay, and specifically in the area or the junction, there's something called parieto-occipital junction. Parietal-occipital junction in the dominant hemisphere can result in Gertzmann syndrome. Okay, and remember there is something called finger agnosia, and there is another term called object agnosia. So there is a difference. So it's not enough to just memorize. You have to know because you may be confronted with such a patient. So what's the meaning of if each, for example, what's the meaning of acalculia? So you are not in schools try to pass the exam and that's it. So you are trying to memorize things without understanding. You are in practice and you may see patients like this complaining of such thing. So you have to study in depth. Okay, so what's the meaning of acalculia? Yeah, have an issue with calculation, simply. Yeah, agraphia. Okay, as the name implies, difficulty with drawing or writing. Okay, finger agnosia or agnosia.
Inability to identify the finger.
Yeah, like which is the index and thumb and so on. Left-right disorientation. Enable, yeah.
Confusion in right and left.
Yeah. So if you ask the patient to point as your right side, for example, they can't. Okay. They have an issue with right to and left, which is right, which is left, but they don't have problem with which is upper or lower or which is front or back. The issue with right and left. All right. And this is like copy paste from Kansky. And according to the parietal lobe, if it is in the dominant, we will find Gardner syndrome. If it is non-dominant, we will see other findings. Dressing and construction apraxia. Again, you have to know what is the meaning of this. By the way, it is called the constructional, not constitutional, I believe, because it's written in Kansky constitutional, but in all other references, it is called constructional apraxia. And something called spatial neglect. What's the meaning of spatial neglect? So for the sake of time, remember, this happens with what? Non-dominant loop, okay? So for most of us, which is the non-dominant lobe? For most of us, like 95% of people.
Right.
The right, okay. So, and the right parietal lobe, controls the left side of the visual field, right? So if we given the patient this paper with these lines, and we ask them to cross each line vertically, okay, they will cross only the right side. They neglect the left side. So we given this paper and with their eyes open, both eyes are open. They neglect the left side of the paper. They mark only, or they cross the lines on the right side. Okay, they neglect the left half of the field because the left half of the field is controlled by the right parietal lobe, which is the non-dominant in most of us. Okay. And if we give the patient like a line and we ask them to cross it in the middle, so this is normal. Again, if they neglect the left side, they will mark it towards the right side. Okay, so this is the meaning of spatial neglect in non-dominant parietal lobe affection. Last thing about this MCQ, this point, impaired optokinetic nystagmus with the tape going to the left. This is true. This is correct. Okay. What's the meaning? Let's discuss this point further. Now, just a brief overview of optokinetic nystagmus. So, optokinetic nystagmus is a form of physiological nystagmus, and it can be induced by visual tracking. And we can elicit it by asking the patient to fixate in a moving stimulus while they remain stationary. A classic example is when you look out of the window while riding on a train or in a car. So this is a good example. In practice, we can use an optokinetic strip like this one, or we can use an optokinetic drum. All right. So now imagine this is the patient. This minion is the patient. And you are the examiner and you are holding this optokinetic strip in a particular way and you are moving it in front of the minion's eye. Don't forget to ask the patient to fixate on the target you are holding. So it's really important to describe the direction of movement. And here, the direction of movement from the patient's perspective, not from your perspective, not from the examiner's perspective. The same as we said before while documenting the visual field. So, for example, in this video, I'm moving the strip from left to right, from the minion or from the patient's perspective, okay? We can simply say the movement is to the right. So here the strip is moving to the right from the patient's perspective. This test is performed binocularly, but it can also be done monocularly, especially if we want to document the visual function in each eye separately. So what happens next? The eyes, the patient's eyes, follow this moving stimulus with smooth pursuit movement in the direction of the motion. So, for example, in this case, to the right, and this is called the slow phase. You see here, the animation here. Now, as if this is the patient's eyes. So you see, the movement is smooth pursuit movement to the right. Okay. Then followed by a quick corrective movement in the opposite side to the left. And this is the fast phase. Because we have now two components, this optic nystagmus is classified as a jerk nystagmus. Slow phase, pursuit, followed by fast phase. And you know, the direction of the nystagmus, the direction of the jerky nystagmus is defined by the fast phase. So in such example, direction of this nystagmus is left. And we can document this in a table. So let's summarize. If you are moving the optic neck strip to the right, as shown here, this elicits right smooth pursuit movement following the stimulus, followed by quick fast phase to the left. This is called jerky nystagmus, and the direction is to the left because the direction of the nystagmus is the direction of the fast phase. So this is another example to fit our MCQ. This is the patient, okay? And the patient is asked to look at the optic kinetic strip or the drum, which is moving towards the patient's left. There must be pursuit movement to the left. So patient's eye should move to the left. This is the first phase. Pursuit movements are controlled by the ipsilateral parietal lobe. And that's why I inserted these vectors. So we need the left parietal lobe. So if we have a lesion in the left parietal lobe, this smooth pursuit movement will be affected. We call it impaired. Okay. That's why in our case, because the patient has left parietal lobe, we have also impaired optic kinetic nystagmus with the tape going on or moving to the left. Now, speaking of optic kinetic nystagmus, I'd like to mention an important concept that you may come across during your studies or even in your clinical practice. There is a term, isolated homonymous heminopia. What do we mean by isolated? It means that the patient presents with purely ophthalmic manifestations. So the only abnormality is the homonymous heminopic visual field defect with no associated neurological deficits. If you remember when we talked about lesions at the level of the optic tract or parietal or temporal lobe, they're usually accompanied by other neurological manifestations. This is because these regions contain multiple closely related structures that are involved in functions other than visual pathway. However, in some cases, when the lesion is confined to an area that is dedicated primarily to the visual pathway, like the posterior part of the parietal lobe or the occipital cortex, we may find only isolated homonymous heminopia without any other neurological manifestations. So the patient may present with only a visual field defect, which is why we refer to it as an isolated homonymous heminopia. Historically, before the era of modern neuroimaging, clinicians relied on a certain clinical rule known as Coogan dictum. You see here, Coogan dictum. According to this dictum, we can use optic nystagmus to help differentiate the location of the lesion. So if the nystagmus is impaired, this suggests a parietal lobe lesion, most commonly due to tumor. All right. And on the other hand, if optic nystagmus is preserved, this points toward an occipital lobe lesion, which is most often due to an infarction. You can find all what I said on this slide. Question number 6. I want someone to name this part.
This is Mayer's loop.
Yeah, finally. Okay. So you see it's looping around what this part, what we call this part in baby blue here. So if we want to describe to someone what is the Mayer's loop, this is like the temporal radiation looped around what? This is the chat. Looping around, yeah, horn, the temporal horn of the, so give me a full answer, a temporal horn of the lateral ventricle, right? Again, we have something called temporal lobe lesion. Remember the fact, the fibers from the upper retina are upper in the parietal, which serves the inferior visual field. And the fibers from the lower retina are lower, which serves the superior field. So in temporal lobe lesion, we have contralateral quadrantenopia. We call it pie in the sky. This is really important. By the way, pie in the sky is an analogy. Try not to use analogy too often in your speaking, in formal situation or with your colleagues, because the patient may hear you saying it, and this is not acceptable because you are describing a disease or disorder with something pleasant or unpleasant. So try to avoid using analogies. This is something we can say in teaching or in exams in order to have some fun. Don't say it that often. Okay. Other manifestations of temporal lobe, this is from Kanisky. I'm trying to point out or to shed the light on some important points. Whenever you say visual hallucinations, you have to say it formed or unformed. So you have to say formed visual hallucinations because visual hallucinations is an important topic. It's written in Kanisky and well written in American Academy. So temporal lobe lesions result in formed visual hallucinations. So I grouped the manifestations into like some groups. The first two lines relate to ophthalmology, okay? Like contralateral upper quadrantenopia and formed visual hallucinations. Once you remember hallucinations, we have another hallucinations because temporal lobe also has a center for smell and taste. So we have also paroxysmal, olfactory, and gustatory hallucinations. We call it alternate fits because actually this is a kind of epilepsy. And that's why there is a seizures here. Also, we have something called receptive aphasia or dysphasia, but it should be in the dominant hemisphere, all right? So make sure that the lesion in the dominant. Plus other finding like contralateral hemiparesis and hemisensory disturbance. By the way, it's really important to say receptive aphasia because we have other types of aphasia. The alternate fits this because there is something called uncus here in the temporal lobe. And receptive aphasia because we have something called vernix area involved with comprehension of written and spoken words, so it might be affected in temporal lobe lesions. Because we have another area called Broca's areas, lesion in this area can result in expressive aphasia. Okay, and you have to know about what's the meaning of aphasia in the first place. What's the meaning of aphasia, by the way? Issues with speaking, when it comes to receptive aphasia, for example, they can speak fluently, but they say meaningless things. Doesn't make sense. And they're not aware of their situation and they can't understand spoken and written words. I need someone to read aloud this slide. It's from Kanisky. Again, when you study, try to read aloud because in the exam, you are gonna speak to the examiner aloud. So you have to practice saying everything aloud.
Visual field defect consists of contralateral superior homonymous quadrantia, pie in the sky, because the inferior fibers of optic radiations, which subserve the upper visual fields, first sweep antero-inferiorly Mayer's loop into the temporal lobe around the anterior tip of the temporal horn of the lateral ventricle. Associated features are likely to include contralateral hemisensitive disturbance and hemiparesis because the temporal radiations pass very close to the sensory and motor fibers of the internal capsule before passing posteriorly and rejoining the superior fibers. Other features of temporal lobe disease include paroxysmal olfactory and gustatory hallucinations, uncanine fits, fond visual hallucinations, seizures, with receptor dysphasia if the dominant hemisphere is involved.
Thank you so much. So you see receptive dysphagia if the dominant hemisphere is involved. Most of the time it is the left because most of us are right-handed. Question number 7. It's an easy one. I need someone to speak, like don't use the chat.
This is a visual field showing left homonymous hemianopia respecting the vertical midline, and this seems to be incongruous.
Congruous or incongruous?
Incongruous.
Okay. And what else? And what we can describe this area? What we call this? This is the central area, so it has
macular sparing.
Yeah, someone is helping you. It's macular sparing. Yeah, I talked about it in the previous class. So the macular sparing, it means the central area, like center 10 degrees, for example, are spared, okay, here and here. So actually, this is almost congruous. So the model answer for this question is actually left homonymous hemianopia, congruous, and macular sparing. And it points at the occipital cortex. Which occipital cortex, by the way? Right or left?
Right.
So the opposite. Whenever we talk about occipital lobe lesions or occipital visual cortex affection, we usually say macular sparing. So why the macula is spared?
Dual blood supply.
It has not a dual circulation.
So you said dual blood supply, so something related to the blood supply, and the second reason, because I wrote here too. Okay, so let's start with the most important one, the dual blood supply. So as you can see, the occipital cortex supplied by, where is it?
Posterior cerebral artery and
see, posterior cerebral and where is middle cerebral here? Okay. And the second reason is the large cortical representation for the macula. So only the center 10 degrees, like a huge area here. Okay, this is from American Academy. So the other reason is the large cortical representation of the macula. Okay, so we're done with 7 questions now, and let's move to some silly questions. Number 8, which one is correct, A or B? B, yeah, excellent. So actually this is from Kanis. So the central fibers are located in the core of the optic nerve. So it has an implication actually in glaucoma. So this shows you how it is important to know a little bit about the anatomy and don't ignore illustrations. Number 9, comment on this nice photo. We have a girl, the same girl. Yeah, there is a finding. I know it's not an abnormal finding, but from the ophthalmic perspective, we can give it a name, like a sign. Say it again.
Tilt.
Head tilt. So someone said head tilt. So that head tilt describes the first photo. How about the second one? So collectively,
Chin down.
Chin down with right fist turn. So collectively, we can say we have abnormal head posture, but we know that the cause of this abnormal head posture is
congenital superior oblique palsy.
No. Okay, actually, but this taken from a website for hairstyles, something not related to medicine. Give some
Patient visual field is covered by his ears.
Yeah, the girl adopted this posture because her hair on this side is causing some kind of visual field. All right. So, and she still interested to see binocularly, so that's why she adopted this abnormal hip posture. She wants to use her both eyes, but because of her hair, she adopted abnormal hip posture. The message from this question: in some patients with visual field defects, they may adopt abnormal hip posture. This is like something reported. So suppose someone is asking you about what are the causes of abnormal hip posture, you have to mention the commonest causes, like paralytic strabismus, as someone said, forced nerve palsy, and so on, nystagmus with null point, ptosis, for example, refractive errors. But at the bottom of the list, you can also add visual field defects. So visual field defects can result in abnormal hip posture. Okay? Of course, in this case, it is something artifact because it's iatrogenic, or let's say it's induced by her hair. But we are talking about disorders. Yeah, visual field defects can result in abnormal hip postures. So if you have a case like a child with abnormal hip posture and everything is normal, no strabismus, no ptosis, no refractive errors, don't forget to check their visual field. Do confrontation test at least. All right? According to one reference, visual field defect and uncorrected refractive errors found to have a prevalence of less than 1% of the causes of abnormal hip posture. So yeah, it's not common, but it's there. As you can see here, this photo from this book, the book is all about homonymous visual field defects. Can you imagine? So here, this patient, look at the letter B here. This patient has right homonymous heminopia. So the right side of the visual field is missing. Remember, we say it is missing. We don't describe it as black or dark. We depict it as black or dark, but the patient would say something is missing. Okay, so remember, when the lesion involves the optic nerve, chiasm, or retrochiasmal pathways, the visual field defect presents as a missing area. So it's a negative scotoma. All right, negative scotoma. However, when the visual field defect is due to a retinal lesion or something anterior to the retina, such as vitreous opacities, the defect or the scotoma is positive. So the patient may describe a blackish area. So back again to our patient, there is right homonymous heminopia, and this means that visual information from the nasal retina of both eyes is affected. Okay? For the patient to have an idea of the whole scene, look at letter F here. The patient may adopt right face turn. So the face turn is toward the heminopic side. Along with the scanning eye movements, there is something called scanning eye movements. The patient can somewhat compensate for this visual field defect, and they can able to have an idea about the whole scene. And by the way, this explains the basis for prescribing prisms in hemanopic patients. When it comes to prisms, the base should be in the direction of the hemanopic field. So in our case, it would be base out in the right eye and base in the left eye. To recap, this shows that patients with visual field defects may have an abnormal hip posture. All right, so visual field assessment might be part of your workup for a case with abnormal hip posture. The fun time now, we're done. Now it's time to play Kahoot game. We have like 15 questions. The first one is demo. So there is no score, there is no marks, grades for the first one, just to get familiar with the game. It's a single best answer. So you will have a stem and 4 choices. You have to pick one. I encourage you, or I recommend, to read all the answers because it's a single best answer. You have to choose the most accurate one. And there is a timer for each question. So try to answer before the time is up. But once click on a choice, there is no way to go back. So make sure that you click on the right answer. Again, this is a test to think on your feet, to think quickly and correctly, because you need this in the exam. You need this in your practice. Try your best. Use your educated guess based on your knowledge. As they say in MCQ, You already have the right answer in front of your eyes, so you have to pick it quickly and correctly. If you answer quickly, you will get a higher score than another one who answered like a bit late. Okay, nice. The majority answered it correctly. Habit trigger is associated with high false positive errors, and we answered this in this class, but someone missed it. Again, got confused and answered incorrectly. Yeah, the correct answer is optic tract, and as you can see, others also got confused. We are talking about homonymous hymenopia, so the lesion should be post-chiasmatic, after the chiasm, okay? Yes, exactly. Cecocentroscotoma, this is described with Leber's hereditary optic neuropathy. So the message of this question is whenever you have an optic neuropathy, you have to know the well-known or the common visual field defects associated with this optic neuropathy. Okay. Like, yeah, correct answer is in red, RPD, because this is a bilateral condition. So we don't expect finding RPD in a bilateral condition. So actually this is the correct answer. And the question asked about the least, okay? Yes, we talked about this. Thank you for answering it correctly, all of you. Yeah, thank you for those who answered correctly. Hymenopia is always on the same side. This may suggest arteriovenous malformation. The message behind this question is that migraine is among the causes of visual field defects. So you have to read about this also. And not all migraine is benign. because it might be a red flag for arteriovenous malformation if the hemianopia is always in the same side. Yeah, thank you for those who were very attentive, all of the above, because all of these are synonyms. Functional, the same as non-organic, the same as hysteria, all are similar terms. And the visual field is a spiral visual field seen in this condition. Yeah, thank you. Yeah, right, homonymous hymenopia. So the aim of using the music, the background music, to add some distraction, to distract you. Yeah, nasal step. Yes. The idea behind this question is really important to know a lot about the glaucomatous visual field defects and how to differentiate it from, for example, other optic neuropathies or other neurological disorders, Anderson criteria, and so on. Yeah, thank you. It's object agnosia due to affection, bilateral affection of the occipital-temporal projection. This is something beyond the primary visual cortex. So this is one of the higher cortical dysfunction. Thank you for answering it correctly. Next. Yes, exactly. The others are like almost respecting the vertical meridian, but the first one, A, is like an arcodisctome. Yeah, thank you. Prosopagnosia can't identify familiar faces like friends, family, and even themselves. Yes, I didn't write redox phenomena or redox phenomena, but the other name for it is statokinetics. They can't see stationary object, but they can see moving object. All right, thank you for those who answered correctly. And if you want to take your knowledge to the next level, any of these you should know the meaning and what is the lesion, how you would check for it, or how the patient would describe it. Okay, nice. 4 out of 6, I think, answered correctly. If you know, the blind spot is a scotoma surrounded by a normal visual field. So in the previous field, there is an isopter excluding the blind spot. So the blind spot is outside the scene area. So bearing means exposed, one of the findings in glaucoma. Yeah, thank you who answered correctly in the chat. Yeah, spatial neglect. If you ask a patient to draw something, they will neglect the left side because the lesion is in the right parietal lobe. Next. The last question, by the way. Yes, okay. So yeah, the right answer is at least 4. All right. Because actually there were 3 people holding a camera in the photo, but don't forget there is someone who was photographing them. So at least 4. Let's see the top 3 winners. was the third place. So I have an issue with pronouncing these names. All right, so I'm gonna ask those who won to say their names. So let's start with the third place. So can you
It's me,
say
Dr. Ghada. Heba.
Heba? Okay, so the second place.
Dr. Sendamarai, ma'am.
All right, congratulations. And the first place?
I'm Dr. Pranshu Goyal.
Are you a vitreoretinal surgeon?
Yes, ma'am. Fellow.
Okay, fellow. Okay, yeah, surgeon and fellow. Yeah,
Surgical fellow.
a promising surgeon, inshallah. So I asked someone during the game itself the question about spatial neglect and asked it should be in the non-dominant parietal, and then I said parietal or temporal, and someone said temporal, but actually it's parietal, and that proves my saying that it's really important to study hard and to practice because it's very easy to get confused. So spatial neglect, according to Kanisky, non-dominant parietal lobe lesion, not temporal. All right. So we're done with the 10 sets of questions, and the remaining part, some closing slides. The first point I'd like to emphasize in these closing slides is that whenever we encounter a visual field defect, we must always consider two possibilities: true defect or an artifact. One of the most important causes is poor test reliability. In Humphrey perimetry, this is assessed using the reliability indices, which include fixation losses, false positive errors, and false negative errors. And of course, you know the terminology is slightly different in Octopus, so it's worth becoming familiar with the corresponding terms used there. Also, other causes of artifacts include incorrect entry of the date of birth, the patient's date of birth, also incorrect refraction, some artifact related to lens rim artifact, lid or brow ptosis. We usually say ptosis results in superior visual field defect, but actually, to be like precise, we should have said an artifact or like pseudo superior visual field defect, because if we repeat the visual field with taping the upper eyelid, this visual field will disappear. Also, pinpointed pupil, like severely myotic pupil. And finally, device-related errors such as a dim projection bulb. When we move to true visual field defects, we can classify them based on the site of the lesion along the visual pathway. This includes lesions at the level of the retina, optic nerve, chiasm, and retrochiasmal pathway, namely the optic tract, lateral geniculate body, and the occipital cortex. And don't forget that the cause may be more anterior, such as in the cornea. Here, I'd like to remind you of an important concept. There is no inverse relationship in the anterior segment causes, okay? So if we have like upper corneal opacity, results in superior visual field defect. The inverse relationship applies only posterior to the nodal point. So a lower retinal detachment, as I said earlier, will produce an upper visual field defect. In addition to these causes, migraine can also lead to visual field defects. We should also be aware of functional visual field defects. The other names are non-organic, non-physiological, which include hysteria, the other name for hysteria, convergence disorder, and malingering. Another important classification, other than the localization of the lesions along the visual pathway, is glaucomatous versus non-glaucomatous or neurological disorders. And also don't forget to revise Anderson's criteria. We can also classify visual field defects as central or peripheral. So I encourage you to review this classification and try to add additional information to this slide. And lastly, and last but not least, you may be given a normal visual field printout in the exam. The aim here is simply to assess your ability to systematically interpret the printout, describe each section, define some terms, okay, comment on everything. So don't underestimate these simple cases. And don't be surprised if you're given a normal visual printout. As a reference, I'd recommend the Atlas of Visual Fields by El-Abedin. It contains minimal text and focuses mainly on visual field images. However, all the examples are from Humphrey Perimetry. Still, it is a very useful source. Now, let's us recall the example from Kahoot game. Remember when I asked about which one is more likely to be glaucomatous visual field defect, the correct answer was A. So this is the right eye, nasal step, the left eye. We have some arcuate scotomas, lower and upper. These are classic features of glaucoma. And most importantly, they don't respect the vertical meridian. They do respect the horizontal meridian, however. Okay? But there must be something called nasal step. The other options, B, C, and D, do respect the vertical meridian. Of course, we don't see the whole printout. You can give better idea about the field if we see the whole printout. B and C show homonymous hemianopia, while D shows bitemporal hemianopia, incomplete bitemporal hemianopia. Finally, it's important to be familiar with different types of visual field printouts. Starting with Humphrey Visual Field Analyzer, you should be able to interpret the entire printout, not just the grayscale or the gray tone printout, all the components found in the printout. So this is an example, by the way, of an enlarged blind spot. You should know its dimensions and recognize that it should be surrounded by normal sensitivity. But here, in this case, the blind spot extends to the 24-degree margin here, which is normal, of course. And you should be familiar with the causes of an enlarged blind spot. Here we see an octopus printout, which differs slightly from Humphrey in terms of plots and terminology. And this one is a Goldemel kinetic perimetry printout. This is the one I used in Kahoot with bearing of the blind spot. So you see this isopter excluding the blind spot. So we have bearing or exposure of the blind spot. And this is, as we said before, Amsler chart. And we have 7 charts. Every one serves a particular function. So now, as you can see, this is a full printout from Humphrey. On the left side here, I'm just giving you an example. This is called full threshold. If I enlarge this here, strategy full threshold. But here on the right side, it's called CETA standard. So according to some of the previous candidates' experiences, they ask you about everything. What's the meaning of this strategy? What's the meaning of the other strategy? So every point here counts. Every point you have to know about it. And also you see this tracking, gaze tracking at the bottom of the printout. And also like here, the glaucoma hemifield messages. And also by using Humphrey, we can have the Eastman binocular functional test. And this is really important for driving and vehicle licensing agency to assess if a driver's peripheral vision meets legal UK standards. For example, for Group 1 drivers, they must have a horizontal field of at least 120 degrees and at least 50 degrees on each side, with no significant central defects within 20 degrees of fixation. This slide is about, again, localizing a lesion along the visual pathways. And this is really important. You can organize your answer the way you like, but here I'm trying to give you some important points. We can localize the lesion from ophthalmic points, other neuro manifestations, other systemic manifestations like hormonal imbalance, for example, and finally, of course, by imaging as a final result. When it comes to ophthalmic manifestations or points or features, from the pattern of visual field, laterality, monocular or binocular, congruous or not congruous, pupils examination, fundus examination, and also visual acuity and color vision. Just to recap pupils examination, because if we have a lesion before the lateral geniculate body, pupils are affected. But from the lateral geniculate body all the way up to the occipital cortex, pupil examination is normal. Fundus examination, there is no optic atrophy, generally speaking, after the lateral geniculate body. So in the retrogeniculate pathway, fundus examination is normal. Because if you remember, the optic nerve is second-order neurons and fibers relay in the lateral geniculate body. So if we have a lesion before the lateral geniculate body, resulted in optic atrophy, and we talked about the optic atrophy patterns in optic tract lesion and optic chiasm, and of course if we have an optic nerve lesion. And that's why I inserted here an alarming triangle at the optic chiasm, because it's an important station. The pathways after the chiasm is called retrochiasmal pathways. In the chiasm, we have heteronomous hymenopia or bitemporal hymenopia. But after the chiasm, it's homonymous hymenopia. So after the chiasm, the visual field defects are collectively called homonymous hymenopia. And another important station is the lateral geniculate body, because after this station, fundus examination and pupil examination are normal. So what does it mean, this term, retrochiasmatic pathway? Means the pathway along the optic nerve, lateral geniculate body, optic radiations. And what do we mean by retrogeniculate pathway? It means the pathway after the lateral geniculate body. Here, this slide is about congruity. This term applies to homonymous hymenopia. Homonymous hymenopia might be complete, as shown here, or incomplete. And then incomplete can be further subdivided into congruous, like this, like exactly the same, and incongruous. Let's read aloud this part. A homonymous hymenopia may be incomplete or complete. In the context of incomplete hymenopia, congruity refers to how closely the extent and pattern of field loss in one eye matches that of the other. Almost identical field defects in either eye are therefore highly congruous, while mismatching right and left visual field defects are incongruous. And here is the most important part. Hymenopia, secondary to pathology in the anterior retrochiasmal visual pathway. Retrochiasmal pathways. What is the importance of mentioning retrochiasm? Because it must be retrochiasmal. Any homonymous hymenopia must be retrochiasmal. So in the anterior retrochiasmal visual pathways, it's characteristically incongruous. While that due to pathology further back, like in the posterior optic radiation, the best example is the occipital cortex, manifests a high degree of congruity. Okay? This slide shows you an important fact that I mentioned a couple of times before, that the visual impulses from the upper retina travel superior along the visual pathway here. And in here is the parietal lobe, and here above the calcarine fissure in the occipital cortex. And of course, visual impulses from the lower retina travel inferior along the visual pathway. So here you will find it in the temporal lobe, and again, finally below the calcarine fissure or calcarine fissure. And as you know, the upper retina serves the lower visual field, and the lower retina serves the upper visual field. So this anatomy is preserved along the visual pathway, except for the lateral geniculate body when things are a bit complicated. Let's see this question or this point. Neurological disorders starting from the chiasm results in bilateral visual field defects respecting the vertical meridian. Why? Here is the answer. First, there is a kind of topographic representation of the nerve fibers that we talked about it before. And then, because nasal and temporal retinal fiber are segregated at the chiasm. Okay, so the nasal fibers cross, temporal fibers pass uncrossed. As a result of this anatomical fact, visual field loss due to chiasmal and retrochiasmal lesions is characterized by defects that align the vertical meridian in both fields. Okay, so starting from the chiasm and retrochiasmal pathway, there must be bilateral visual field defects respecting the vertical meridian. And that's why if we have a monocular visual field defect, this means that the lesion is anterior to the chiasm, like the optic nerve, something in the retina, something like monocular. So again, this general rule, monocular field points to lesion anterior to the chiasm. And any lesion starting from chiasm should be bilateral. However, we have some exceptions. One of these exceptions, sometimes we have a lesion posterior to the optic nerve, yet monocular. And this example is when the lesion is at the anterior part of the occipital lobe, and this results in temporal crescent visual field defect in the contralateral eye. Just a reminder of this schematic representation. If you remember here, there's something called temporal crescent here and temporal crescent here, okay? So this part actually served by the extreme nasal of the corresponding eye. This field served by the extreme nasal of the corresponding eye. So the right temporal crescent is served by the extreme nasal part of the right eye. And also here, the left temporal crescent is served by the extreme nasal of the left eye, nasal retina of the left eye. And since they are nasal, they cross in the chiasm, and the final station here in the most anterior part of the occipital cortex. So if we track here by animation, the right temporal crescent, this extreme nasal will cross to reach the left anterior part, most anterior part of the occipital cortex. So if we have lesion here, we have temporal crescent field defect here. Again, this shows you the full field. This is temporal crescent represented in the most anterior part of the occipital cortex. Another important topic, it's a bit advanced, is about disorders of higher cortical function beyond the visual pathway. So we have some disorders. Some of them are written in Kansky, like Anton syndrome, hemispatial neglect that we talked about, it, redox phenomena, simultagnosia. So you can read about these in the American Academy, and also written the site of lesions. For example, in Anton syndrome, so the site lesion is here, okay? It's actually in the occipital cortex, V1, primary visual cortex. Something like object agnosia and prospagnosia related to the occipitotemporal, inferior temporal cortex. So I think balance syndrome is also written in Kansky, so you can read about this from the American Academy. And we shared some of these in the Kahoot game. Like this patient can't identify an object by vision, but if they use other senses like touch or description, they can identify it. So this is actually called object agnosia. And the lesion should be bilateral in the ventral pathway, affecting the occipitotemporal projections. And also we shared about this, the patient can't identify familiar faces like family, friends, famous people, and even themselves. We can say face blindness or prospagnosia. And if you remember, prospagnosia due to lesion here in the ventral pathway here. Now, in this slide, I'm trying to highlight the importance of checking the visual field, at least by confrontation, as a routine part of comprehensive ophthalmic examination. And this is not age restricted. Even very young children like this infant can be assessed. Generally speaking, we perform visual field testing monocularly, like visual acuity. But under certain conditions, it can be done binocularly. So as I mentioned earlier, one example is instrument, binocular visual field. Another situation is in children. because many kids object to occlusion of one eye and become upset. So we may start with binocular visual assessment. In this photo, we try to attract the infant's attention by holding an object, like very colorful object in front of their eyes. Once fixation is established, another assistant introduces a second stimulus from the temporal side. Okay, if the infant turns their head towards the stimulus, the preferred stimulus, this gives us a rough idea that the temporal field is more or less intact on this side. And we can repeat it on the other side. In this photo, they are mainly assessing the temporal fields, but we can use it in different directions. Keep in mind that one of the tumors associated with chiasmal syndrome in children is craniopharyngioma, which typically presents with bitemporal hemianopia, often affecting the inferior fields. So the purpose of this slide is to demonstrate that temporal field assessment is important in children. And we shouldn't use any stimulus that produce sounds, because we want to attract the child's attention by stimulating their vision and not by hearing. If the child is old enough, we can perform monocular testing as in adults. We can use the finger mimicking, finger counting. So here, vision of the right eye, ask the child to look at the examiner's corresponding eye or nose and ask them to imitate the fingers present on each side. In the bottom image here, another useful technique that we can use is to turn the child's head to keep the testing eye in the abducted position. Okay, this way helps maintaining fixation on the examiner's face, because most kids are often uncooperative and they may move their eyes around. Finally, in these closing slides, I'd like to share some references that I find very helpful, and I frequently use them while preparing my lectures. One useful resource is the well-known one, Neuro Ophthalmology channel by Dr. Andrew, which provides short focused videos on different topics. Also, we have Professor El-Abedin, especially for understanding visual fields interpretation and glaucoma visual field defects. Another valuable resource is the CyberSight library. You can find it on YouTube, but I recommend to check the website itself because some of the lectures are not there in the YouTube channel. Also, this is a very helpful YouTube videos about visual fields, and it is divided into parts, very organized, by Michigan Medicine. And if you are interested in reviewing full cases, testing yourself, quizzes, or reading articles, this is a really helpful, it's like invaluable resource, Canadian Neuro Ophthalmology Group website. And we have Radiopedia. You can find cases like for review about a case along with the radio imaging. So yeah, finally, we're done with the confrontation visual field testing assessment and everything related to it. The next class will be about something, it's a riddle. I'm a doorway without a door, yet I control the flow. I change my size with light, though I have no muscles of my own. I sit in the center of a colored wall, ever observing, yet blind myself. Who am I? Yeah, I know the riddle is singular, but actually the second class is about, let's see.
Pupil?
No. Pupils, okay? In order to remember that, you have to check both pupils, okay? Yeah, we're done with this meeting. Thank you so much for your patience and your participation, and I can't wait to see you again in our next class.
Dr. Ghada, I
Yes.
just want to say thanks to you. Actually, this is the first time I am attending your live session. And I used to watch your videos, and that's why, Alhamdulillah, I was able to clear my FRCS this January.
Yeah, congratulations. Yeah.
Thank you so much. Thank you so much. Your all the videos, lectures are very helpful for every candidates, and I would like to recommend to all the candidates do watch the videos, like for the examination and all. Thank you so much.
Yeah, I'm really happy for your success and also for your kind words. Yeah, you made my day. Thank you so much. And the final thought here, this is the island of vision, hell of vision, as we mentioned in the first class. So yeah, this with patience and dedication, you can reach your goal. And the road may be steep and hard, but this is the smartest way to study and to achieve your goals. Avoid this area because you will find the blind spot, bottomless pit. Any questions before I end up the meeting? All right. Thank you so much and see you again, inshallah. Have a great day. Bye-bye.
Thank you, ma'am. Thank you so much.
You're welcome. Bye-bye.